Welcome back to the deep dive. We're here to make complex clinical topics clear, structured, and honestly useful for you. Today, we're diving deep, really systematically, into male reproductive disorders.
Yeah, we've got a good set of clinical sources here, and our mission really is framed around those key learning objectives. The ones you need for quick recall in practice or for exams. We're aiming to understand how these conditions start the etiology.
Right, the pathophysiology, too.
Exactly.
Mhm.
And then how we find them, the assessment data, the diagnostic tests, and critically, what we do about them. Therapeutic management, yes, but especially the priority nursing care. What outcomes are we aiming for?
Perfect. It's about connecting those dots: cause, signs, treatment, and expected results. We've broken this down into 4 parts. Let's kick off with part 1, focusing on issues often rooted in vascular health, starting with something very common: erectile dysfunction, or ED.
So ED. It's crucial, I think, to get the clinical definition straight from the start. Our sources are clear. It's not just about getting an erection, it's the inability to attain AD, maintain one that's firm enough for, well, satisfactory intercourse.
That maintain part seems key. That's often the main complaint, isn't it?
It really is. The rigidity just doesn't last. Now, thinking about the causes, the etiology,
Hmm.
people often jump to stress or age,
Yeah.
and those play a role for sure.
But the sources say physical damage is the most common culprit, like a plumbing issue.
Pretty much, yeah. It's overwhelmingly physical. We're talking damage to the arteries, the smooth muscle, the fibrous tissue down there.
Yeah.
And the big players causing this damage are chronic conditions. Diabetes is huge.
Right.
Kidney disease, chronic alcoholism, atherosclerosis, that hardening of the arteries we see everywhere else, and just general vascular disease. Think
Yeah.
about it. If the vessels feeding the heart are clogged, the tiny ones in the penis, they're definitely at risk.
So the pathophysiology, the actual mechanics, it links back to that vascular damage. How does it break down?
It's about something called the veno-occlusive mechanism. Okay, so normally blood rushes in through the arteries, right? That pressure is supposed to squeeze the outflow veins shut, trapping the blood, keeping things rigid.
Makes sense.
But with these diseases, maybe the inflow isn't strong enough, or the muscle and tissue are damaged, fibrotic. They just can't clamp down on those veins effectively. So blood leaks out.
Resulting in incomplete erections or ones that fade quickly.
Exactly. Then you add age into the mix, sensory activity decreases, tissues change, testosterone levels might drop a bit, all contributes.
And we can't forget iatrogenic causes things we do in medicine. What about medications?
Oh, definitely. Certain antihypertensives, especially some older beta blockers, they mess with vascular tone. That's a known factor. And then some psychotropic drugs, the sources point out, haloperidol, chlorpromazine specifically.
Okay.
And then you layer on the psychogenic stuff, depression, major stress, fatigue, and that awful cycle. Performance anxiety leads to fear of failure, which just makes ED worse. It's complex.
Moving to assessment, the patient's complaint is usually clear, but how do we figure out if it's primarily physical or psychological? Efficiently, I mean.
That's where a really neat diagnostic tool comes in. The nocturnal penile tumescence and rigidity test, NPTR.
Okay, what's that?
Well, the sources mentioned men typically have 3 to 5 natural erections during REM sleep over about 8 hours. This test just monitors whether those are happening.
And why is that so useful?
Because if a guy complains of ED when he's awake, but the NPTR shows he's getting normal, firm erections while asleep, well, that tells you the basic hardware, the nerves, the arteries, the tissue, it's working.
So the problem is likely psychological or maybe situational stress or medication timing.
Exactly. But if the NPTR shows no decent nocturnal erections, then you know you're looking at a physical cause, probably vascular. That points you towards more specific tests.
Yeah.
Like cavernosometry, actually measuring the pressures, the inflow and outflow, or doing intercavernous injections of drugs that cause erections, just to see visually how the blood vessels respond.
Okay, let's talk treatment. Therapeutic management, the oral meds, the PDE5 inhibitors, sildenafil, tadalafil, vardenafil, they're usually first line, right? They relax smooth muscle, boost blood flow.
They are. But there's one absolutely critical safety point. A priority nursing concern. Non-negotiable.
Which is?
Nitrates. You must ask every single patient, are you taking any form of nitrate? Like nitroglycerin for chest pain.
Why is that combination so bad?
Because together they cause massive vasodilation. Blood pressure can just plummet. It's potentially fatal hypotension, really hard to treat. Absolute contraindication. Cannot stress that enough.
Got it. Huge safety alert. What other risks with these meds?
Priapism. That prolonged painful erection lasting more than 4 hours, it can cause permanent damage.
Who's at higher risk for that?
Patients with certain blood disorders, mainly sickle cell disease or leukemia, their blood is just different, more prone to sludging or clotting in those small vessels. So you need to assess for that specifically and tell them, look, if an erection lasts too long, you need emergency help immediately.
If the pills don't work or can't be used, what's next?
We move to local treatments.
Mm.
Self-injections directly into the penis papivarine or prostaglandin E.
Wow.
They work well, but, needles.
Yeah.
Then there are tiny urethral suppositories, like alprostadil. Effective, but they can cause burning. And importantly, it kind of kills the spontaneity, right? Because the erection is drug-induced, not from natural stimulation.
Right.
Occasionally, transdermal nitroglycerin paste is tried, applied locally. Mixed results on that one.
But even before we get to the drugs or injections, the nursing role starts right at the beginning, doesn't it, with the conversation?
Oh, absolutely. Creating a safe space is priority number one. Men often feel intense shame, embarrassment talking about this. The assessment has to be non-judgmental.
And look for reversible factors first.
Yes. Start there. Ask about alcohol. It's a depressant, messes with blood vessels. Ask about recreational drugs. Those often interfere with normal sexual function. Address those easy wins first. #tag be varicose, the bag of worms.
Okay, shifting gears slightly, but still in the vascular realm, structurally speaking. Varicocele, known often as the bag of worms.
Yeah, that description is quite visual, isn't it? It refers to this cluster of dilated, twisty veins, the pampiniform venous complex, right there on the spermatic cord. The cause, often unknown, idiopathic. But fundamentally, it's like varicose veins, but in the scrotum. Defective valves in those spermatic veins let blood pool.
And the main reason we care clinically, the big connection, is infertility, right?
That's the primary concern, yes.
Uh-huh.
Why does this bundle of swollen veins cause infertility? It's about temperature.
Heat.
Exactly. That mass of veins acts like a little radiator, raising the temperature inside the scrotum. Testes need to be slightly cooler than the body for sperm production, spermatogenesis, to work properly. The extra heat damages sperm production and really hurts their motility, their ability to swim. So it's a major cause of low sperm counts.
Assessment-wise, how does this usually present? Is it always painful?
Often it's actually asymptomatic. Or the patient might just report a sort of dull ache, maybe a heavy feeling down there, especially after standing all day. The key diagnostic finding comes from palpation, feeling the area while the patient is standing.
And you feel?
You feel those dilated, tortuous veins, a bag of worms. But here's the critical differentiator. When the patient lies down, that mass should pretty much disappear. It decompresses because gravity isn't pooling the blood anymore.
Okay, that makes sense. Which leads to the big diagnostic alert, the red flag finding.
Right. If the patient lies down and that mass does not shrink or disappear, that's worrying. Very worrying.
Why? What does that suggest?
It suggests the backup isn't just faulty valves and gravity. It suggests something is actively obstructing the venous drainage higher up, like pressure from a tumor, maybe renal, maybe retroperitoneal, blocking the return flow. A non-decompressing varicocele needs an urgent workup for a secondary cause.
So assuming it's a primary varicocele, what's the management plan and what are the expected outcomes?
Treatment is usually surgical repair of varicocelectomy, where they tie off the bad veins, or sometimes embolization, blocking the veins non-surgically. The main goal, the hoped-for outcome, is restoring fertility.
But it takes time to see results.
Yes, and that's crucial patient education. The whole sperm production cycle takes roughly 70 to 90 days. So any improvement in sperm count or motility won't show up on tests for several months after the procedure. They need patience.
And post-op nursing care, what are the priorities?
Standard stuff, really. Good pain control, making sure they understand incision care. Scrotal support is important, helps minimize swelling and tension. And definitely instructions to avoid heavy lifting or strenuous activity for about 3 weeks while things heal up properly.
All right, part 2. We're shifting now from those more chronic vascular or structural issues to conditions that usually present acutely with pain, fever, inflammation. And a key theme here you mentioned is how the cause often depends heavily on the patient's age.
That's a really critical point for assessment and management. Treating acute scrotal pain in a 25-year-old versus a 65-year-old often involves very different thinking. Let's start with orchitis, inflammation of the testicle itself. #DJA. Orchitis, testicular inflammation, so orchitis. Inflammation of one or sometimes both tests. It's actually pretty rare as a primary infection. Usually it's either an infection ascending up from the epididymis next door, or it's spread systemically, like from a virus.
Which brings us to that classic sort of textbook connection, mumps.
Right. Mumps, orchitis. It's clinically significant, especially because it tends to hit postpubertal males who weren't vaccinated. And the timing is characteristic. The testicular inflammation usually starts about 4 to 6 days after the parotid glands swell up the classic chipmunk cheeks.
So if you see a young adult male, unvaccinated, with sudden testicular pain a week after having mumps symptoms,
Architis should be high on your list, definitely.
and the potential complications here aren't trivial, they go beyond just the pain, right?
Oh, absolutely. The inflammation and swelling can lead to testicular abscesses. It can cause the testes to shrink, later on atrophy due to damage, fibrosis, scarring, and the big one, if it affects both sides, it can lead to permanent infertility or sterility. That's a major concern.
How does it typically present during assessment? What's the classic picture?
It's usually a sudden onset, severe pain, often radiating up into the groin, high fever, chills, often nausea and vomiting, because the pain is so intense. And when you look, the scrotum is red, very swollen, warm to the touch, and incredibly tender.
Okay, so priorities for nursing care. What do we do first?
Well, given the infection and inflammation, priority number 1 is getting the prescribed meds on board. That means analgesics for the severe pain, and if it's bacterial, the right antibiotics.
And non-pharmacological comfort measures.
Strict bed rest is key. Scrotal elevation using a rolled towel sling basically helps drainage and reduces swelling. And specifically for orchitis, cold applications, ice packs.
Okay, hold on. Why cold? We often use heat for pain. Why cold here?
Good question. Because in this acute inflammatory phase, the main goal is to decrease metabolic demand of the tissue, limit swelling, and sort of contain the inflammation. Heat would do the opposite, increase blood flow, potentially worsen the edema and pain. We want to cool things down, calm the fire.
Got it. Cold for orchitis. And what about patient education? What do they need to know?
They absolutely need to understand the risk of sterility, especially if mumps was the cause. And like with any infection, hammering home the importance of finishing the entire course of antibiotics is critical, even if they start feeling better quickly. Stops recurrence, prevents complications like abscesses. ###B epididymitis.
Epididymis inflammation.
Okay, moving next door anatomically to epididymitis. Inflammation of that coiled tube, the epididymis, where sperm mature. This is apparently the most common cause of infection within the scrotum. And here's where that age difference in cause really comes into play. Hugely important distinction here. For younger men, let's say generally under 35, sexually active, if they come in with epididymitis symptoms, your primary suspect, until proven otherwise, is a sexually transmitted infection ascending from the urethra.
Like chlamydia or gonorrhea?
Exactly.
Good.
Chlamydia trachomatis, Neisseria gonorrhea, those are the main culprits in that age group.
But then you hit, say, 40 or older, and the picture changes completely.
It does. In older men, the cause is much more likely to be a UTI or prostatitis bacteria ascending from the bladder or prostate, usually coliform bacteria, especially E. coli. And often, there's an underlying issue like BPH, benign prostatic hyperplasia, causing incomplete bladder emptying,
Okay.
which sets them up for UTIs.
Let's talk presentation. What does epididymitis look like?
Again, severe unilateral pain is key. Like orchitis, you get the red swollen scrotum, fever, nausea, vomiting. But a really characteristic sign you might see because of the pain location and intensity is the duck waddle walk.
Duck walk.
Yeah, they take these short shuffling steps, often leaning forward a bit, trying desperately not to move or put any pressure on that incredibly tender epididymis. It's quite distinctive if you see it.
And labs would show infection.
Oh yeah, white blood cell count will be sky high, often 20,000, 30,000, even higher. Confirms a significant bacterial infection is underway.
Management-wise, how does the nursing care line up with orchitis? Similar?
The core principles are very similar, yes. Bed rest, often for a good 5 to 7 days initially. Scrotal elevation, cold packs during that acute phase, antibiotics, of course, pain management.
But because of the STI link in younger men?
Right. A critical piece is making sure STI testing is done, the results are followed up, and crucially that partners are notified and treated. Otherwise, you just get reinfection cycles and continued spread.
What about expected outcomes and patient education for preventing it from happening again?
We tell them to wear scrotal support, like a jock strap, for maybe up to 6 weeks as things heal, just for comfort and support. If the cause was UTI-related, pushing fluids like 3 liters a day is really important to keep the urinary tract flushed.
Any long-term risks?
There's a risk of it becoming chronic epididymitis, which can be difficult to manage. And if it affects both sides, there's a potential risk for infertility. But one thing to reassure patients about, erectile dysfunction is not a typical complication of epididymitis. That's usually a separate issue. ###C prostatitis, prostate inflammation.
All right, let's focus on the prostate itself now. Prostatitis. Inflammation of the prostate gland, usually bacterial again.
Most commonly, yes. And again, usually E. coli ascending from the urinary tract. Chronic bacterial prostatitis is actually the most common type we see overall.
But there are non-bacterial forms too.
Yes, there's this category sometimes called prostatodynia, or non-bacterial prostatitis. The patient has all the symptoms, the pain, the urinary issues, but you can't find any evidence of infection or inflammation. It's thought to be maybe related to muscle spasms in the pelvic floor or chronic tension.
So what are those symptoms? What does the patient complain of?
It's often a mix of urinary irritation urgency, frequency, burning when they pee combined with pain, often a nagging low back pain, or pain deep in the perineum. Some men report pain or just general discomfort during or after ejaculation.
And acute versus chronic looks different.
Definitely. Acute prostatitis hits hard and fast, sudden high fever, chills. On rectal exam, the prostate is incredibly tender, swollen, feels boggy. Chronic cases are more subtle. The DRE might just show an irregular, maybe firm and tender prostate. Symptoms can wax and wane.
Nursing management has to tackle both the infection, if present, and that significant discomfort.
Correct. Antibiotics are key, often for a long course, especially in chronic cases. Analgesics for pain, sometimes antispasmodics to help with the bladder irritation. But for comfort measures, here's a difference from orchitis.
Okay.
We use warm sitz baths and sometimes even rectal irrigation with warm water.
Ah, so warmth here, not cold, like for the testicle. Why the difference?
Because with prostatitis, especially the non-bacterial kind, a lot of the pain comes from tension and spasm in those pelvic floor muscles surrounding the prostate. The warmth is incredibly soothing. It helps relax those muscles and relieve the pain.
That makes sense. What else for comfort?
Stool softeners are really important. Straining to have a bowel movement puts direct pressure on that inflamed prostate, which can be agony. Softeners make it easier.
And patient education. What should they avoid or do?
Diet matters. Tell them to avoid bladder irritants. Alcohol, caffeine, really spicy foods. Those can flare up the urinary symptoms like frequency and urgency. For chronic bacterial cases, sometimes the doctor might do periodic prostate massage. The idea is to help express trapped pus or bacteria from the prostate ducts. And for the prostatinuria folks, reassure them that normal sexual activity is usually fine, even sometimes helpful, as long as it doesn't cause pain.
Okay, moving into part 3. The theme here is urgency. These are conditions where quick, accurate assessment and intervention are absolutely critical. Delays can mean permanent damage. We have to start with the big one. Testicular torsion. Hashtag a testicular torsion, the surgical emergency.
Yeah, torsion is the absolute urological emergency. What happens is the spermatic cord, that structure containing the blood vessels, nerves, the vasi deferens, it literally twists on itself.
Like wringing out a towel.
Exactly like that. And it acts like a tourniquet, completely cutting off the blood supply, both arterial inflow and venous outflow. This leads to ischemia, lack of oxygen, and very rapid tissue death, necrosis of the testicle.
And this happens mostly in younger guys.
Primarily. It can happen from birth up to about age 20, but the peak incidence is right during adolescence, typically ages 12 to 18, often happens spontaneously, sometimes after minor bumps or even just vigorous activity.
Given how fast tissue can die, what's the absolute #1 priority nursing concern?
Time. Urgent intervention is required to preserve testicular viability. That's it. The clock is ticking loudly. Salvage rates plummet after about 6 hours of ischemia. By 12 to 24 hours, the testicle is usually gone, non-viable. This needs immediate recognition, immediate surgical consult, immediate prep for the OR.
It can be tough to tell apart from really bad epididymitis just based on pain. What are the key assessment findings that should make you scream torsion?
The onset is usually sudden, often excruciating pain, might wake them from sleep. Nausea and vomiting are very common because the pain is so severe. On exam, the affected testicle often sits higher than the other one. We call that high riding. It's swollen, red, very tender.
But the definitive clinical sign, the one that really differentiates it.
It's the reflex check, the cremasteric reflex. Normally, if you gently stroke the inner thigh, the testicle on that side should pull up slightly. In torsion, that reflex is almost always depressed or completely absent on the affected side.
Oh, why?
Because the nerve pathway running through that twisted cord is interrupted. That absent reflex is the classic critical finding that points strongly away from epididymitis, where the reflex is usually normal, and towards torsion.
Okay, absent cremasteric reflex equal probable torsion. Diagnostics confirm with?
A Doppler ultrasound will show little or no blood flow to the affected testicle, and management is straight to surgery, no delay.
What happens in the OR?
First, they try to untwist the cord detorsion to restore blood flow. Then, critically, they perform an orchiopexy. They stitch both testicles to the inside of the scrotal wall.
Both? Why both?
Because the underlying anatomical issue that allows the twisting, often a poor attachment called a bell clapper deformity, is usually present on both sides. Fixing both prevents it from happening to the other testicle later. If, unfortunately, the twisted testicle is already dead, necrotic, then they have to remove it in orchiectomy.
Post-op care focuses on
Pain control is huge. Scrotal support, again, cold packs to manage swelling, and really reinforcing activity restrictions for those first few weeks to allow healing and prevent disruption of the fixation sutures. ###B, hydrocele, fluid accumulation. All right, let's talk about another scrotal swelling, but thankfully one that's much less urgent, the hydrocele. This is simply a collection of fluid.
where does the fluid build up?
It collects between the layers of the tunica vaginalis, which are the membranes surrounding the testicle. In babies, it's often congenital, related to development. In adults, it's usually secondary.
Meaning caused by something else.
Yeah, often develops after an injury or an infection like epididymitis or some other inflammation of the scrotum. Either the body starts making too much fluid or it's not reabsorbing it properly. It can get quite large and uncomfortable, but it's generally benign.
The key diagnostic trick here is differentiating it from something solid, like a tumor, or something complex, like a hernia-containing bowel.
And the classic bedside test is transillumination.
Shining a light through it.
Exactly. You take a bright pen light, darken the room, and shine it right through the scrotal mass. Because a hydrocele is just clear serous fluid, the light will pass right through and the whole sac will glow or transilluminate. A solid tumor won't do that. Neither will a hernia-containing bowel. It's a quick, easy way to get a strong clue.
How is it managed? Does it always need treatment?
Not always. If it's small and not bothering the patient, often just watchful waiting, supportive care. If it gets very large, causes pain, or they're concerned about appearance, treatment options are aspiration, draining the fluid with a needle, though it often comes back, or surgical removal of the hydrocele sac itself, called a hydrocelectomy.
And post-op nursing care after a hydrocelectomy.
Pretty similar to other scrotal surgeries. Scrotal support is essential. Cold packs for swelling and pain, good pain medication. Reassure them that absorbable sutures are usually used, so no removal needed. Focus on comfort, especially in the first day or two.
Okay, final part. We're zooming in on the prostate gland now, looking at conditions that often affect older men and significantly impact urinary function, hyperplasia, and neoplasia, or cancer. Let's start with the very common one, BPH, ###, benign prostatic hyperplasia, BPH.
Right, benign prostatic hyperplasia. This is basically an overgrowth, a non-cancerous enlargement of the prostate gland, specifically the cells in the central part. It's extremely common as men age, almost inevitable if you live long enough.
And the core problem is just simple mechanics. The enlarged gland squeezes the urethra.
That's the essence of it. The prostate surrounds the urethra right at the bladder outlet. As it enlarges, it compresses that tube, obstructing the flow of urine.
This isn't just about having to pee more often, though. The complications can be serious, affecting the whole urinary system.
Absolutely. The bladder muscle has to strain against that blockage to empty. Over time, it gets thick and hypertrophied. This poor emptying can lead to bladder stones forming from stagnant urine. Chronic urinary retention is a big risk.
And pressure can back up?
Yes. If the bladder can't empty properly, pressure can build up and back up into the ureters, causing them to dilate hydrator. And eventually, that back pressure can damage the kidneys, leading to renal insufficiency. It's a cascade effect.
So what are the classic symptoms we need to assess for? What does the patient experience?
The symptoms are primarily obstructive. Things like a weak urinary stream, difficulty starting the flow. That's called hesitancy, having to stop and start again. Waking up multiple times at night to pee nocturia. Feeling like the bladder isn't fully empty even after going. And sometimes overflow dribbling.
On exam, the digital rectal exam, DRE, what does BPH typically feel like?
Usually the prostate feels symmetrically enlarged, kind of rubbery or firm, but generally smooth.
Diagnostics often involve checking how much urine is left after voiding.
Right. We use a bladder scanner right after they pee to check the post-void residual, or PVR. If there's more than about 100 ml left in there consistently, that significant retention confirms the obstruction is causing problems.
And blood tests, PSA.
We check PSA, prostate-specific antigen, and sometimes acid phosphatase levels. But it's important to understand why. We're mainly checking these to help rule out prostate cancer, which can coexist or present similarly. A high PSA doesn't automatically mean cancer, but it warrants further investigation. BPH itself can elevate PSA somewhat.
Okay, management. What are the medication options?
Two main classes. First, alpha blockers, like tamsulosin, Flomax. These work relatively quickly by relaxing the smooth muscle in the prostate and bladder neck, opening up the channel.
Okay.
Second, the 5-alpha reductase inhibitors, like finasteride, Proscar. These actually work to shrink the prostate gland over time by blocking the conversion of testosterone to its more active form in the prostate. Takes longer to see effects, maybe months.
Any major side effects with those?
So the alpha blockers can cause dizziness, especially when standing up due to blood pressure effects. The 5-alpha reductase inhibitors, finasteride specifically, can unfortunately cause sexual side effects in some men, decreased libido, erectile dysfunction. That needs to be part of the discussion.
If meds aren't enough, surgery is an option. The TURP transurethral resection of the prostate is still common, right?
It's still considered the gold standard surgical treatment. They go in through the urethra and basically shave away the obstructing inner part of the prostate tissue.
And post-TURP nursing care is quite involved. A lot of focus on bladder irrigation.
Yes. Continuous bladder irrigation, or CBI, is standard right after TURT. Its whole purpose is to continuously flush the bladder with sterile saline to prevent blood clots from forming and blocking the catheter. Some bleeding is expected after the resection.
What's the key nursing action for managing that CBI?
You have to constantly monitor the drainage coming out and adjust the flow rate of the irrigation going in. The goal is to keep the drainage in the bag a nice light pink or clearer. If it starts looking dark red, like ketchup, that means more bleeding, so you need to increase the irrigation flow rate immediately to wash it out faster and prevent clots.
And if the output suddenly stops?
That's an emergency. It likely means a clot has formed and is blocking the catheter. First, check for kinks in the tubing. If none, you'll likely need an order to gently irrigate the catheter manually with a syringe to dislodge the clot. Never force it. Obstruction causes intense bladder spasms and pain.
Accurate intake and output monitoring is critical here too, right? Because of all that irrigation fluid.
Absolutely essential. You must meticulously track how much irrigation fluid has gone in and subtract that total volume from the total volume collected in the drainage bag. Only then do you know the patient's true urine output. Messing this up gives a completely false picture of their fluid balance and kidney function.
Speaking of fluid balance, there's a potentially serious complication called TURP syndrome.
Yes, this is a major alert. It's rare, but dangerous. During the TURP, some of the hypotonic irrigation fluid can get absorbed directly into the bloodstream through open blood vessels in the prostate bed.
What does that cause?
It causes rapid fluid overload and, crucially, dilutional hyponatremia, low sodium levels due to dilution. The nurse needs to be vigilant for the signs. Bradycardia, slow heart rate, maybe new hypertension, nausea, and especially mental status changes like confusion or restlessness.
What do you do if you suspect TURP syndrome?
Stop the irrigation immediately. Notify the surgeon and medical team. This needs prompt management to correct the fluid and electrolyte imbalance.
What about other post-op education? Things the patient needs to know.
Reassure them that feeling the urge to void around the catheter is normal. The balloon stimulates that sensation. But they absolutely must not strain to pee or have a bowel movement. Straining increases abdominal pressure and dramatically raises the risk of bleeding. Also, tell them to avoid drugs that can cause urinary retention, things like anticholinergics or common over-the-counter decongestants until cleared by their doctor. Have B testicular cancer.
Okay, let's pivot to cancer now. Starting with testicular cancer. Unlike BPH and prostate cancer, this one hits younger men, right?
That's right. It's the most common solid tumor in men between the ages of 15 and 35, much younger demographic.
Do we know what causes it?
The exact cause isn't known, but there are clear risk factors. The biggest one by far is a history of cryptorchidism, an undescended testicle, even if it was surgically corrected years ago. That significantly increases the risk. Other possible factors include trauma to the testes or maybe having had mumps or chitis previously.
Assessment often starts with the patient finding something themselves.
Very often. The most common, and often the only early sign, is a painless lump or hardened area discovered during testicular self-examination, TSE, or maybe just a feeling of heaviness or a change in the size or consistency of the testicle. Any change needs checking out.
Later symptoms might include
A dull ache in the lower abdomen or groin, maybe unexplained weight loss or fatigue. If it has spread, metastasized, then you might see other signs.
what, depending on where it spreads?
If it goes to the lungs, maybe a persistent cough or shortness of breath. GI disturbances. Back pain if it spreads to the retroperitoneal lymph nodes. sometimes even gynecomastia, breast enlargement, due to hormonal changes caused by certain tumor types.
How is it diagnosed? Imaging and blood tests.
Scrotal ultrasound is usually the first step to confirm there's a solid mass.
Mm.
Then blood tests for specific tumor markers are crucial. Alpha-fetoprotein, AFP, and beta-human chorionic gonadotropin, beta-HCG.
Are those markers diagnostic on their own?
Not entirely. They're more used to help stage the cancer, see how extensive it is, monitor how well treatment is working, and detect if the cancer comes back later. LDH levels can also be elevated. The definitive diagnosis comes from removing the testicle.
So management starts with surgery, removing the affected testicle.
Yes, an orchiectomy is the primary treatment. Depending on the type of cancer and whether it has spread, that might be followed by chemotherapy or radiation therapy.
What are the absolute priority nursing education points after diagnosis and before/after surgery?
Number 1, emphasize the critical importance of lifelong monthly testicular self-examination, TSE, on the remaining testicle. There's an increased risk of developing cancer there too, so early detection is key.
And addressing concerns about fertility and sexual function.
Hugely important. Discuss sperm banking before the orchiectomy. This gives them the option for future biological fatherhood and alleviates a major source of anxiety. Also, reassure them that removing one testicle generally does not affect sexual function or testosterone levels long term, assuming the remaining one is healthy. Hashtag see prostate cancer. And finally, prostate cancer. Unlike testicular cancer, this is overwhelmingly a disease of older men, usually over 40, and it's the most common non-skin cancer in men, typically an adenocarcinoma.
Where in the prostate does it usually start?
Often begins in the outer part, the peripheral zone, which is why it might not cause urinary symptoms early on, unlike BPH, which starts centrally. High levels of testosterone over a lifetime might play a role in its development.
A major concern with prostate cancer is its tendency to spread, metastasize. Where does it typically go?
It spreads readily through lymph channels and veins, and its most common site for distant spread, unfortunately, is bone, particularly the pelvis and the spine.
That has huge implications for symptoms and quality of life.
Massive. Which is why assessment is tricky. Early prostate cancer is often completely asymptomatic. It's often found incidentally on PSA screening or DRE.
So what are the later signs, especially those suggesting spread?
You might eventually get urinary symptoms similar to BPH, trouble voiding, weak stream, maybe blood in the urine, hematuria, frequency. But the real red flags suggesting metastasis, especially to bone, are things like persistent new onset back pain, especially pain that doesn't go away with rest, migratory bone pain that seems to move around.
And neurological signs?
Yes, nerve pain or sciatica-like symptoms if it's pressing on nerves near the spine, or most critically, any new lower extremity weakness or new problems with bowel or bladder control.
Why are those neurological signs so urgent?
Because they could indicate spinal cord compression. If the cancer metastasis in the spine grows large enough to press on the spinal cord, it's a neurological emergency. It can rapidly lead to permanent paralysis if not treated immediately with steroids and often emergency radiation. This is a top priority assessment finding to act on.
Management options are broad, depending on stage and patient factors.
Right. Options range from active surveillance for very slow-growing cancers to hormone therapy to lower testosterone, radiation, either external beam or implanted seeds, brachytherapy, or radical surgery to remove the entire prostate gland, radical prostatectomy.
Post-prostatectomy, what are the main nursing concerns and potential long-term issues?
Two big ones are urinary incontinence and erectile dysfunction. Incontinence is common initially and often improves over time, but can be permanent if the urinary sphincters are damaged during surgery. Impotence is also a significant risk. Infertility is guaranteed after radical prostatectomy.
So nursing focuses on
Teaching pelvic floor exercises Kegels intensively, both before and after surgery, to help with urinary control, providing support and resources for managing incontinence and ED, and always vigilant monitoring for those signs of metastatic disease, especially bone pain or neurological changes suggesting spinal cord compression, even years later. Hashtag outro.
Wow, we have covered a vast amount of critical clinical information today, from, chronic issues like ED all the way to surgical emergencies like torsion and complex cancers.
Yeah.
To try to synthesize this, maybe focusing on just 3 absolute priority nursing takeaways, what should they be?
Okay, 3 key things. First, for ED meds,
Mm-hmm.
nitrate check. Always ask. It's a potentially lethal interaction. That assessment is non-negotiable.
Got it. Number 1, nitrates and ED drugs don't mix.
Second, testicular torsion. That absent cremasteric reflex, Recognize it immediately. It screams surgical emergency, and time is tissue. Speed matters more than almost anything else there.
Right. Absent reflex, act fast. And number 3.
Post-2 care for BPH, specifically managing that continuous bladder irrigation. Know how to titrate it to keep the output light pink or clear, and be hyper-aware of the signs of 2 syndrome, that fluid overload and low sodium. Catching that early is crucial.
Perfect. Nitrate check, absent reflex, CBI, 2-repeat syndrome awareness. So zooming out, thinking about the bigger picture, what patterns did you see across all these conditions?
Well, it's striking how often underlying chronic diseases, like diabetes and vascular problems, set the stage for reproductive issues like ED. Then you see the clear split in infection causes STIs in younger men, UTIs BPH-related in older men, for things like epididymitis. And it really highlights how critical our clinical judgment is, knowing when bed rest and ice are right versus when immediate surgery is the only answer. It's about preserving function, fertility, and comfort.
That brings up a final thought for you, our listener. We talked about how many of these conditions, hydrocele, varicocele, even testicular cancer, are often first noticed by the person themselves. So think about this. With this deeper knowledge of the signs like transillumination telling you it's likely fluid, or a varicocele not decompressing being a red flag, what responsibility does that place on individuals for self-awareness and prompt reporting? And maybe what other common medications, beyond the ones we hit hard today, might have urological side effects you should keep in the back of your mind? Something to chew on.
Great questions to consider. Thanks for diving deep with us today.
Absolutely. We'll catch you on the next deep dive.